Health and Wellness, and Dr. Jacqueline Biseso McKenzie, Chief Medical Officer of Jamaica. And we're also joined by Dr. Karen Webster Carr, our Principal Medical Officer and National Epidemiologist. We'll begin this evening with the latest update on COVID-19 in Jamaica, and our Minister will give us the update.
Thank you very much, Stephen. Good evening, ladies and gentlemen. Thank you for joining us. The team was introduced earlier. Dr. Webster Carr will be featured in due. Webster Carr will be featured in due course. But on both sides, I have the Permanent Secretary and the Chief Medical Officer. So today we're going to give an update in our usual style, and then beyond the updates, we will have questions from the media. Beyond that, though, I'm going to urge those online to listen on for a few presentations, very brief, but nevertheless important. One, looking at the vulnerable groups within the society. A critical part of the way forward is to assess who are most vulnerable to COVID, and I think it's important from a public health perspective, particularly in the context of opening up or further removal of restrictions, to look at those vulnerable groups, individuals, communities, and then to map an approach to give some added support to those who are most at risk. So we will outline the issues around vulnerabilities. Dr. Webster Carr, epidemiologist, will do that. Then from there, we will look at our risk management matrix, essentially looking at the risks that we will have to confront and address in the months to come, and how we intend, in a very general way, for now anyway, outline how we intend to manage those risks. And I'm going to ask the PS to quickly run through that, the PS and the Chief Medical Officer. And we will also give a very brief overview on how Jamaica to date is positioned in the context of COVID globally. In other words, how we are positioned as it relates to what we have done, the results we have had as it relates to the rest of the world. So some interesting discussions, part of the COVID conversation that will take place after the initial information that I will now proceed to outline. So thanks again for joining. So our island, as most of you will now be aware, we lost our 10th victim, Jamaican, to COVID. 87-year-old female from Kingston and St. Andrew, who passed over the last 24 hours. And of course, we want to express our condolences to the family, to the friends of this particular individual. It certainly is something we hope does not happen, but unfortunately part of the risks associated with this disease, particularly for someone at that age and persons with underlying conditions. It is a sobering reminder, ladies and gentlemen, of the need to remain vigilant, and for us to ensure that as we move forward, every one of us will be an important part of the response to COVID-19, even with the lifting of the restrictions. As we have said, everyone counts. Beyond that, we have seen over the last 24 hours, and this is a positive development, another period when we have had no new case of COVID-19. So I'm happy to report that we have had no new case over the last 24 hours. The total number of confirmed COVID-19 cases remain at 591. There are 368 Jamaicans who have recovered to date, with 7 new additions in the last 24 hours. So 7 new recoveries and no new positive case. That puts the island's recovery rate at 62.3%. So there's an improvement in our recovery rate, which again is worth recognizing and celebrating. And we thank the public health system for the support to those individuals. In terms of case classification, at this time there are 92 imported cases. The 92 imported cases are categorized in the following way: 34 cases from before the travel restriction of March 22nd, 2020, 34 cases from cruise ships, 15 cases from flights returning from the UK, and 9 cases from flights returning from the US. In other words, since we started to repatriate our Jamaicans, whether from cruise ships or otherwise, we have had a fairly high increase in the number of cases since the March 22nd date. So that's 34 plus 15 plus 9. Before that time, we had 34 cases. In fact, the UK cases, the 15 UK cases are total 49 are from the cruise ships. Okay, so a correction there. The 15 UK cases are actually from the cruise ships, those that came in by air, but nevertheless were employees of a particular vessel. Further, 217 cases are contacts of confirmed cases. 27 are local transmission cases not epidemiologically linked, and 235 are linked to a workplace cluster. And of course, we know the workplace cluster is in Portmore, St. Catherine. 20 are still under investigation. The gender gap, the gender variation, 340 or 58% of the positive cases are females, 42% or 251 are males, and they range ages between 2 months and 87 years. Of the 591 cases confirmed with COVID-19 to date, 368 have recovered, that's a 62.3%. 10 or 1.7% have died, which is well below the global average, but nevertheless still unfortunate. And of note, there are 2 currently critically ill cases, and we have no moderately ill cases at this time. So 2 critically ill, the rest are for the most part asymptomatic or just mildly ill, which is also positive. There are 213 or 36% of active cases currently under observation. So in other words, of the 213 active cases, 2 are critically ill, and those would be our immediate concern, even while we maintain the isolation for the others. In terms of the control re-entry program, since April 29th, 2020, there have been some 2,320 entries. So persons have come in since April 29th, 2,320. All have been tested, and 58 have tested positive to date. And I say to date because we're still awaiting some results. So we will inform the public as we get back those tests. I want to just pause to really recognize the efforts of the public health team, who have really worked long hours to collect the samples, those at the lab or lab techs, the technical expertise who have worked to get the results of samples or get samples tested. And of course, we've been working with many other agencies, national security, customs, immigration, transport, JUTC, and others. But to cover this number in a relatively short space of time is a demonstration of collaboration and a commitment by the government to manage this process through to a successful completion. And I believe we have done well at it so far, or to date. In terms of testing and surveillance, the island's testing numbers are up. We are now completed 13,813 tests to date. 199 samples were tested in the last 24 hours, and that's from 2 of them repeat samples. Of the 13,813 total tests done, then 591 positive, 13,190 have returned negative results, and 32 results are still pending. So our testing numbers have gone up and have been going up fairly significantly. Later on, Dr. Webster Carr will do her comparison to show the number of tests that we do proportionally compared to the rest of the world and where we stack up, because we know that testing has been an issue, a point of discussion locally. In terms of our infirmaries clearly represent for us one of the vulnerable communities, and we'll elaborate more on that, but We did have one positive case that was discovered, which we had announced. From then, we would have gone in and moved to test a number of persons, all persons at that particular facility in St. Anne, but we continued also on our program to test all infirmary workers, our caregivers across the country, and that process is ongoing. We have done some 460 tests so far, primarily of employees, but also of patients, certainly in the case of those at the St. Anne facility. And we have had one positive, so one positive of the 460, representing a 0.2% positivity. We will have to continue to monitor and to manage the activities as it relates to infirmaries. And as you know, in the announced policy or orders by the Prime Minister, the issues around visitation, which have been put on hold for now, represents one of the measures to attempt to control the potential risks of spread within those facilities, and that continues. In terms of the general hospital surveillance, as of June 3rd, 2020, 62 tests have been done in the general hospital surveillance system, with one returning a positive result. As of June 4th, 455 tests have been done on our healthcare workers. 8 have returned a positive result, so 8 of 455. And 47 cases to date have been identified through our respiratory surveillance system. That is through our sites across the country where persons turn up with symptoms and they are automatically tested, and the results are therefore determine what we do with these individuals. I would want to say, as it relates to the 455 tests done of healthcare workers with 8 positive results, is an indication again of the risk that our frontline workers face each day. Remember, they are the ones who have to go out there and interact. They are the ones who travel into the communities. They are the first point normally of contact as it relates to positive cases and the public health infrastructure. And even though they gear up and prepare themselves for that risks, anywhere in the world that you go, you will find that they are most at risk, and invariably some unfortunately do end up getting the virus. We do, however, do what is necessary and what we can to secure them through PPEs, but also through treatment in the public health system. Nursing homes, as is the case with infirmaries, represent another vulnerable risk category. And I did announce some time ago that we developed a plan, a protocol, and also had commenced inspections of our nursing homes across the country. And we took time to, I think I had asked the unit with this responsibility to not just focus on registered nursing homes, because there is a recognition that a number of entities operate as nursing homes but are not registered with the ministry for one reason or another, and it's something we need to regularize. But nevertheless, they pose a threat in terms of the spread of the virus, and indeed persons who normally stay in nursing homes are persons with comorbidities, underlying conditions, by virtue of age, represent a particular risk. And if you look anywhere in the world where the virus touches down in a nursing home or an infirmary, we normally have or see deaths resulting because of the weaknesses within those persons' immune system. And so it's very important for us that we manage that process. So 204 nursing homes, including 17 not in our records, have been inspected in recent times over the last number of weeks. 98 were satisfactory, 106 had issues, and we have given some time up to 4 weeks in some instances, for improvements to be done. And the focus here, while it includes trying to get these facilities to register. There's a primary focus of getting them to put in place the infection prevention and control mechanisms to minimize the risk of COVID coming into those facilities, because that is the current challenge that we face that we're trying to avoid. Some of the concerns that we have had, and I go through some of them because I want to appeal to persons who are involved in managing these facilities, but also relatives who have their loved ones in these facilities. Most of these persons staying, these patients who live in these facilities, have family members who take care of them. And it's important that we appeal to family members to insist that these standards are maintained, because that is actually in the interest of your loved ones and your family members. So we've had issues with inadequacy in the training of personnel with regards to cleaning and sanitation procedures, and that's a major focus of our officers. Inadequate hand hygiene facilities, again, standard protocol in infection prevention and control. No isolation area. If someone has symptoms, we have to remove them to an isolation area until they are appropriately assessed. And every facility should have an isolation area. No provision in place for social distancing or physical distancing, ensuring that, common areas are sufficiently spaced out with appropriate seating arrangements, or otherwise dining areas, TV rooms, to ensure that the physical distancing protocol is maintained. Lack of running water in parts of the building where water is essential. So even if there is water, there may need to be adjustment in the plumbing infrastructure. Staff not complying with the PPE requirement, whether wearing of masks or otherwise. Inappropriate cleaning and sanitation chemicals that are used for cleaning the floors and other areas. Inadequate provisions made for additional potable water. Temperature checks for staff entering premises not being done, which is a critical component of the protocol, standard protocol, and temperature checks not being logged. I mention these areas of breach because, firstly, in most cases, they are not that difficult to put in place, frankly speaking. Ensuring that you have proper hand hygiene facilities, ensuring that you have a mask, you do temperature checks. These are not very expensive systems that can be put in place, that should be put in place. And so it really comes down to management. And I really want to appeal both to the operators / managers, to patients, to the extent that they hear what's going on, they should insist, but perhaps most importantly, to those who pay for persons who are their loved ones, family members, to insist that this be done. The team will continue to inspect. We have given reports to each facility indicating where there are challenges and make recommendations for overcoming those challenges, and given dates when inspections will take place. And we will continue to do so in the weeks and in the months ahead. And I see a note here where of the 204 nursing homes, it represents a bed capacity of over 3,000, 3,242, with an 80% occupancy. So there are quite a number of persons in nursing homes based on the inspections that we have done. This would mean that well over 2,500 Jamaicans are in the 204 nursing homes across the country. And this is a large number. And they are vulnerable. And as a consequence, it's going to be important for us to take those measures. So the team will certainly be continuing its observation and its inspection of these facilities and take stronger measures if necessary. So that's it. In summary, we have had no new case to report in the last 24 hours, 199 samples tested, 7 additional recoveries, 2 persons of the total number who are recovering that are critical, and those we have to watch. The rest are either mildly symptomatic or asymptomatic, which is very positive. And that represents the report for today. Over to you, Steve.
Thank you very much, Minister. So we're going to invite our media colleagues on the Zoom to use the raised hand feature to ask your questions to the team. And we're going to begin with Jamaica Social. Just introduce yourself, please.
Good evening, folks. I'm Cassius Watson for Jamaica Social. Two questions quickly to the Minister and as well to the CMO. There's been this general sense that as the easing of restrictions extend, there's some amount of complacency. I'm seeing less people wearing masks. More people bunched and grouped together. So obviously people feel that, we're good to go because not a lot of people are dying in our hospitals from what we're seeing compared to what we're seeing on international news. Jamaica is not under a lot of pressure per se. So, we can, it's back to normal. How do you see this making your role even more difficult now, Minister? The fact that many more Jamaicans will be not repatriate, but many more Jamaicans will be coming from hotspots all over the world as you have now opened up our ports. And how difficult does this now make your job when at a time when people are kind of letting their guard down? And my second question is to the CMO. Have you been getting, what's been the response from people who have registered on the Jam COVID site for testing? Are you seeing any interest there, or what are the numbers, and have you started the process? Thank you.
Okay, so the first question around complacency is a real issue. The truth is that we have, to some extent, we run the risk of being victims of our success. In that, I think, generally speaking, one would have to conclude that as a country, as a public health infrastructure, as a government, collaborating with the entire country, we have done fairly well to manage the COVID threat to date. We've had 10 deaths, which are unfortunate, but as a percentage of overall cases is much lower than the international average. We've seen many recoveries. We have improved our public health infrastructure, adding COVID wards, respirators, PPEs, trained staff, created a level of public awareness so persons are aware. And for the most part, persons have followed through and have benefited from the social distancing and the contact tracing, isolation, and quarantining. So all told, I think, the vast number of Jamaicans who have participated in this process should be commended. It, however, does potentially give an impression that all is well and we can drop our guard. And then, of course, the complacency will set in. The threat is still very real, and with each lifting of restrictions, the threat becomes even more possible to materialize into a reality. And how are we responding to that? Well, we have to continue to, first of all, we have to understand the threat and help the country to understand it, which is why the discussions after these questions will be to elaborate on how we perceive the vulnerable communities that we need to focus on and what is our response to the risks that we perceive. And we need to be clear in our minds as a team how we will approach it, and we think we are. We need the country to be also very clear that with each decision there are associated risks. We cannot guarantee absolute or normal or usual freedoms, which clearly is the desire of all of us in a free society, and also guarantee absolute protection from COVID. Every decision has associated risks. And that's why we think that the everyone counts theme of getting persons to take personal responsibility, the protocols that have been established, we must enforce them. The hospital system has to be prepared to deal with critical cases, and that process has to continue in the months ahead. You would have seen me in one town center in halfway tree handing out masks. The team across the country will be doing more of that. We have to continue to drill in the minds of the Jamaican people that they have to keep focus while they enjoy more restrictions being lifted. They have to understand the associated risks and take the necessary action to protect themselves and by extension their families and communities. And as we get more persons to sign on, we believe it will get better. We can manage the process. If not, then we will have to manage in another way, which is the consequences of infection spread, which will mean hospital care. And we're preparing for that eventuality, although we hope that we don't have as much of that. That's a sort of long-winded way to address your question, but I thought it was an opportunity just to outline the importance of all persons understanding that as we move forward, we have to continue to be careful. CMO, you want to address the second question, please?
All right, good afternoon. Thanks for your question. I don't have the exact numbers. I know that some of the parishes are up fully on the website, and so therefore persons are able to make appointments. We are not able to give a report right now as to the take-up of the site, but I would just want to remind persons that this is an opportunity, especially for the persons who have mild respiratory symptoms who are at home, to get tested. So they can visit the site, the website, and register to be tested. As soon as we are able, we will provide an update as to the numbers that have accessed the site.
Thank you very much, CMO. Thank you, Minister. We're going to go to Althea Saunders.
Hi, good evening. Can you hear me?
Yes, go ahead, please.
All right. So the Ministry of Health had forecasted that up to 2.6 million people could suffer from acute respiratory illness as a result of COVID-19. When we had our first case, I'm wondering now with the opening up if that forecast is being adjusted in any way, or if it had already included the opening up at the time when it was given.
Our epidemiologist will be on shortly to discuss some of the other issues, and I'm sure she would be able to elaborate on that issue. You want to just wait until she comes on, or you want to do her to do it now?
Since she might not be on.
Okay, Dr. Webster, let me ask her to just come on. Just to note, though, that the 2.6 was a combination of the 1 million normal flu season and a 1.6 or so possible additions, and it was over a year, and it depended on several other variables. But I'm not the epidemiologist, so let me allow her just to address it.
Okay, thank you for the question. So we don't expect that to change, because for any virus, after a certain amount of persons would have gotten it, then the susceptible population goes down, and so less and less persons will get it. So the number remains the same. Of course, it's an estimate. And having confirmed cases is not the total picture of persons. So we may have more persons who would have had COVID-19 than can be confirmed.
Okay.
All right, thank you very much. I'm going to go to 18 Degrees North.
Hi, good afternoon, everybody. I want to talk about data. The data that Minister just gave, I'm concerned it's not correct. And the reason is that you just mentioned that there were 34 import cases as of March 22 when the restrictions began on imported or incoming passengers. I got some data from both the CMO confirmed by the press person in your office that the 34th imported case was a Turks and Caicos patient on April 16th. I brought up this issue before about the fact that it would be really helpful to get a full list on a case-by-case basis of each person and a description of where the person is from, where the person came from, that kind of thing, so that we can easily cross-check you on your numbers, because we're getting conflicting data when these numbers come out and we're just expected to accept them, and it's really difficult to accept them when you're being told one thing from one mouth and then another thing from the minister's mouth, you know. So I'd like something that would give us definitive double checking that we can do for ourselves against you. That's one question. The second thing, I'm muted.
No.
It says you're muted. Okay, the second thing I'd like to ask about is the same TCI patient. How many doctors, medical personnel, I know that there were some that were quarantined, but as a result of the quarantine, anybody of them tested positive? So that was the second question. Samuel, I went yesterday to try to get a COVID test. That's another thing. I've been trying for months now to get one, and I just want one. And I heard you just say a while ago that, you know, people with mild respiratory symptoms can get one. So I was just wondering, how come when I went yesterday and have been on the site, I've tried to register, I've been trying to call to get an appointment, that kind of thing, that the people yesterday, for instance, said that there are a huge backlog of cases and my case does not sound like a COVID case, so they turned me back. The backlog, what is the number of pending cases that this huge backlog is supposedly, you know, is? And then, you know, for the other people who may be trying to get on, how do we know how many are getting through? Because my experience might be indicative of other people's experiences. Okay, so those are the three I have. And I'm sorry that I have three others, but I'll just leave those for three right now, because the truth is that I was skipped on Sunday.
Simo, you want to, the first question is around data. I'm not, well, I think we've been consistent with the data, but Simo, you want to go ahead and respond to that?
I'm not sure what was the question about. Where was the discrepancy with the 34th case? What exactly was the question?
34th imported case was from Turks and Caicos.
The 34th?
I'm being muted. Are you hearing me? I'm seeing that I'm
Yes, we're hearing you, Zara. Go ahead.
Okay. Yeah, just to recap. You had told me, and as I said, confirmed by Petrie, 34th imported case was the Turks and Caicos patient, which was April 16th. That's as of, April 16th. And then Minister just said in this press conference that the 34th imported case happened by March 22. That's what he just said, which was when these restrictions went into place. And so the data is not adding up, and I've been keeping track of the data.
No, if I'm understanding, what is being said is that the report from the number of cases that are imported before we close the border was 34. But the report that she knows to be accurate is that the 34th case is the imported case from TCI, which is the patient that went to UA, and that happened in April. So she's questioning when is the actual report, 34th case. Is it before, as the minister just read, before the closing of the border, or is it the TCI patient that came in? What we have to say is that it would have been an oversight on our part, in that the 34th case was the patient from TCI, and therefore it would be that we had 33 cases before the border closing, and the 34th case would have been the imported case from TCI. Okay.
The other question was concerning your request to have a test done. Right. So remember now that when persons do call to request a test, that an interview is conducted. So, because we still are testing for those cases that we think that there is a possibility of COVID-19. So, if you had an interview done and you were told that you were not a priority for testing based on the history that you gave, then I don't want to. I could not, interrogate the history that you gave to say whether or not you would have fit into, the need to have a COVID test. But I would have to rely on the judgment of the medical professionals who answered your call. And it is true that, yes, an interview is conducted, and based on the interview, then the tests are scheduled. So, yes, that is being done. As I said before, we will try to get an update in terms of the numbers of persons that are accessing tests through this method, and we'll provide that update as soon as we can.
And let me just say on that first question, Zara, that there is no there's no attempt at all at somehow hiding the numbers or misrepresenting the numbers, because that certainly would not suit us. I think we have been very transparent in terms of our approach and the management of this process to date. And I see a lot of value in being as open and as transparent as possible. And I have pushed for that, and frankly speaking, hopefully that culture within public health, of course, with the understanding that patient confidentiality has to be maintained and respected. And so our weekly press briefings, our daily releases, not saying that we're perfect, and there may be times when you make an error and you try to correct it when you recognize it. But the commitment to giving the numbers are real, and to giving all the numbers, which is why I've spoken so many different categories. So I just want to reinforce that, because it's so important to the credibility of what we do and the need for us to do this to get the support of the people of Jamaica. So when we say something, they know that we are accurate and we mean what we say, and we say it with all sincerity, and hopefully with the understanding that they will appreciate where we are and define their own role in responding and being a part of the solution.
I just want to add, I would just want to add that many times you will see in our reports persons under investigation. We do take some time to investigate the cases, and sometimes there may be an initial classification that after investigation, it may first be reported as a local transmitted case because we could not find a link. But the investigation continues, and then you may find a link to an imported case, and it becomes a contact. So while I understand that you may be following astutely and trying to match the numbers, I would ask that you take those variances into considerations, because we do have the investigations that are ongoing. We don't tend to close off on the investigations right away, and so therefore as new information becomes available, you may find a shift in how a case is classified. However, our overall numbers will not change, because a positive is a positive and a negative is a negative. But you may find that kind of variance. So where you see that, please feel free to contact us for clarification, and we will be able to provide that.
Thank you very much, CMO. We're going to go to Owen Brown.
Oh. Hello, good evening. You're hearing me, right?
Yes, go ahead, please.
Yes, thank you. Good evening. Yes, I wanted to ask a question of the Minister regarding the positive test from the infirmary. What's the status of that person who tested positive? And for that particular infirmary, are there any additional work being done there to be sure that when it reopens and everything will be okay? And for other facilities, what is it that you're monitoring with these other infirmaries?
Right. So that case was picked up through the routine surveillance of the infirmaries that we started. And this is part of our aim to protect the vulnerable persons within our communities. So the case actually was an asymptomatic case, and that person has remained without symptoms up until now. Now, in terms of the investigations that were done, in that we would have tested all 103, I believe it, residents of the facility, as well as we would have completed the testing of all the workers within the facility, as well as we would have done the contact tracing for the individual, including all his close contacts or persons that he would have come in contact where we would have thought that there would have been transmission. All of that has resulted in negative results. The case remains under investigation because we are still trying to find out how it was that this person would have been exposed. Now, in terms of our measures at the infirmary, we would have done at that time immediately a deep cleaning and sanitization of the facility, and there would have been measures put in place to monitor the residents at the facility and the healthcare workers, and there would have been routine intense cleaning that would have been scheduled on a weekly basis to ensure that we reduce the risk of transmission and exposure if there was any person that may have been incubating the virus. So several measures have been put in place. As you know, we have continued the order for there to be no visitors at the infirmaries because we are trying to prevent anybody bringing in infection into these facilities. And so therefore the monitoring of the workers within the facilities continue.
Thank you very much, CMO. We have a question from the Gleaner with today's conclusion of the arrangement with Bahia Hotel as a quarantine facility. What alternatives have been put in place?
Okay, thank you very much for that question. So the protocols, as you know, have been adjusted, and we are making alternative arrangements for quarantine. For persons who are in isolation, the arrangement is that each region will identify appropriate venues within their region to continue the isolation of persons who are still testing, who still have a positive result from their tests. In the KSA region, we have concluded negotiations with 138 Living, Student Living, 138 Student Living, and our arrangement is for the Southeast region with the 138 Living group.
All right, thank you very much, PS. Just going to take about two questions from social media, and then we move on to our other segment. One question is it now safe to play contact sports recreationally? If yes, what are the restrictions?
Right, so many of the restrictions that are in place in terms of how it is that persons gather are still in place. And so the maintenance of physical distancing is important, and that remains one of the main methods in which we have to stop transmission of the disease. And so therefore it is critical at this point that persons maintain those measures. So I would say for contact sports, we have to hold off on those for a while, or rules in terms of gathering of crowds. That remains, and so therefore where it is that you have persons that are gathering, no gatherings for more than 10 persons are allowed, especially except for those special situations that would have been gazetted by the government. So we still have to maintain, we may be in a time that persons are feeling a little bit lulled, and as somebody had mentioned earlier, maybe feeling a little bit complacent. But I would say to persons that this more than ever is a critical juncture where it is that all Jamaicans have to ensure that they do their part to stop the transmission of the disease. And so therefore it is critical that everybody maintain the measures in terms of personal hygiene, hand hygiene, respiratory hygiene, and ensuring that they keep the physical distancing rules.
Thank you very much, CMO. Just a final question from persons on social media. If most cases of COVID-19 are asymptomatic, how effective do we think our screening process will be for persons entering the island?
Right. So we have to recognize at this time that, there are always risks that are going to be associated with cases that we are going to miss in our surveillance methods. We have, Dr. Webster Carr, our epidemiologist, has pointed out before that the number of cases that we pick up represent a portion of the cases that are out there. Once the virus is in the country, we are going to get cases that are reported through the development of symptoms. We know that a vast majority of persons are going to remain asymptomatic, and so therefore will remain undetected by the public health system. And so at this point, everyone really has to remember that they have to act as if everybody that you come in contact with could possibly have COVID-19 and may be asymptomatic. And so therefore you need to exercise all the precautionary measures that you need to do in order to prevent transmission. Persons that are coming in at the airports, as we change the protocols, as time passes, our response to the epidemic will change. And you will find that presently we are testing persons and we are now sending them home to complete their quarantine period at home. Now, during that period of time, some persons may become symptomatic and they will report it to the public health system, and we will be able to do the necessary monitoring and interventions that may be needed. Many persons will remain asymptomatic but may end up becoming positive for COVID undetected. The literature is showing right across the world, we see different papers that are coming out that are showing that yes, there are a lot of asymptomatic cases, but the level of spread from asymptomatic cases are low.
Let me just say, you did say this was the final question. So this is a good place to segue into our epidemiologist, Dr. Webster Carr's presentation, brief presentation. We put a few slides up on the screen, essentially to help to get the country to come to terms with the vulnerable groups in the society, meaning groups that would be more susceptible to picking up the virus, but also in picking up the virus, they would have the greatest possibility of becoming ill and even critically ill from having the virus. All persons are not going to experience the virus the same way. And, the question was asked about what guarantees do we have. Frankly speaking, there are no guarantees. The screening process is intended to reduce the risk, not to eliminate the risk. It's not an absolute process. It is a calculated method or approach to reduce or to minimize as best as possible the risks. And to the extent that we open up and restore normal activity, and the flip side of that is where the risk profile changes. And what we will see over in the coming weeks and months is a change in the risk profile. Because if we want no risk at all, then it would mean keep everything shut down. Clearly that's not practical, that's not feasible. There are all sorts of implications for that. So as you open up, then you have to now contend with a different risk profile. And what Dr. Webster Carr and her team have spent some time doing is to assessing where that risk is greatest with the intention of deploying the public health resources, personnel and otherwise, to mitigate against that risk. with the intention to informing the public, so you should know whether you fall in that high risk category and what you should do. That's the everyone counts theme, the taking responsibility theme, and the allocation of resources would be guided by that. So we're not doing things in an ad hoc way. It's very planned, it's very managed, and the intention is to mitigate the risk. So Dr. Webster-Carr, you want to just take over on that?
Thank you, Minister. So just to say, when we're looking at risk and vulnerabilities, we look at what are the risks for severe disease. And so we looked at what were the risks for the poorest outcome, and that is death. And all persons who have died, the 10 persons who have died, had at least one comorbidity. And from the pattern diagram, you see that 8 out of the 10 had more than one, and some had 4 or 5 different risk factors for poor outcome. So we looked at different age groups, and we looked at the comorbidities. For persons, we look at our workforce, 20 to 64. 1 out of 2 persons had at least one of selected comorbidities. We selected 6 comorbidities to look at. The usual: hypertension, diabetes, obesity, renal disease, cancer were selected. And that means about 821,000 persons have at least one. So that is a lot, right? 1 out of 2. Right. And then we looked at, suppose we look at 2 or more, then 1 out of 6 persons in this age group had a comorbidity. And when we looked at 3 or more, 1 in 20 had comorbidities. We also...
Just go back to that slide for me, please. Right. So just to be clear, and sorry to interrupt you, but just to try and get the public to understand, you're saying that 820,587, or roughly a third of our population between the ages of 20 and 64 have at least one.
Half. So the population for persons 20 to 64 is probably about 1.7, 1.6. Yeah. So half of those persons actually have at least one comorbidity. The other thing is that probably about 50% of persons with hypertension and diabetes don't even know they have it. And so
basically that comorbidity that we speak of, and I'm trying to be simplistic, so forgive me, but I just want every single Jamaican listening to understand that 821,000 Jamaicans have either diabetes, hypertension, cancer, asthma, one of those, right? And what it means, and probably up to 40% of those, if I recall the statistic around NCDs, don't even know that they have it. Now, what it means, therefore, is that if you were to, we preach the message of knowing your health status, and everything is related. The Jamaica Moves message, knowing your health status, balancing your diet, half an hour exercise a day, is very linked to the NCD epidemic that we have, which factors into this, because what it's saying is that if you have an NCD, a non-communicable disease, a lifestyle-related disease, hypertension, diabetes, heart disease or cardiovascular disease, and you get COVID, it increases your risk and therefore your likelihood of hospitalization and perhaps even critical illness. And the first slide, which showed those 10 persons, back to the first slide for me, if you can, which showed the 10 persons who passed, unfortunately. It showed that 7 of those had cardiovascular or heart-related disease,
including hypertension.
including hypertension. 7 of those had diabetes, which meant that they had more than one.
Yes.
6 age 60 and over. 4 had obesity, so age is also an issue. 2 neurological condition, 2 renal disease, 1 cancer. And what it is showing is that all the persons who passed, the 10 persons, had one, and in most cases, multiple NCDs. And it significantly enhanced the risk that they face, the hospitalization that was necessary, the ICU or high dependency units that they had to be put in to help them to breathe, and tragically, unfortunately, their demise. And it's so important that we understand that's the basis on which we assess who are those vulnerable people. And we say to Jamaicans, know your health status, because that health status will give you an indication of how vulnerable you are and why you need to take extra precaution. And that's the messaging that I want to simplify and emphasize, because it is so important. Go back to the slide for me, please, where Dr. Webster-Carr can,
And we can move,
go to the next one.
Move forward. Just to say, this is the parish distribution. When we look at number of or proportion of the population by parish, we see that St. Thomas is at the highest point, followed by Clarendon. But when we look at absolute numbers, St. Andrew and St. Catherine are the highest. And this pretty much stays the same way throughout. 2 or more, 3 or more, except I believe Clarendon is showing the highest in the 2 or more, and then St. James for the 3 or more.
So what we have done is to outline the vulnerable groups by age and by illness or chronic ailment, NCDs. And then we have broken out the numbers by parishes, so it gives us an appreciation as to not only who are the vulnerable people, but where they are located. Where are they located? And that's a key part of our plan as in public health, to try and identify these persons, identify their conditions, and we have the records because they go to the health centers, they go to the hospitals, and then from there you formulate a plan as to how to deal with them.
Sure.
Go ahead.
So we did a similar exercise for the person 65 years and older, and when we look at that, 4 out of 5 of the persons in this age group had 1 or more comorbidity. 2 of 5 had 2 or more, and 1 out of 9. That is great. That's about 11% of persons, and we see the numbers. So these are, apart from their age as a vulnerability, they also have comorbidities.
So let me explain again, and again, Dr. Webster-Carr, please accommodate me and to the listeners, because I want to break it out in a very simplistic way. That 25,563 Jamaicans who have 3 or more comorbidity. So they could have hypertension, they could have diabetes, and they could have asthma, all 3. And they are 65 years and older. Those persons, and I'm being bold, but I have to say it, would be the most likely to die if they developed a severe case of COVID-19. They would be the most likely to be hospitalized, the most likely to require a ventilator, and frankly speaking, their chances of survival would be less than others who do not have these conditions. And if you opt to the 98,000, it would be 2 of 5 persons having 2 or more. So 98,000 Jamaicans in all parishes either have diabetes and hypertension, or hypertension and heart disease, or cancer and diabetes, they have 2, those would be quite vulnerable too. And in a sense, if you look at it in these terms, ladies and gentlemen, you are getting an appreciation for the vulnerabilities in the society, or the vulnerable persons in the society, and why we have to remain concerned and vigilant, because frankly speaking, these persons are not just numbers. They are our mothers, our grandmothers, our grandfathers, our brothers, our nephew, our neighbors, or us as individuals. And everyone knows someone who falls in that category, which is why everyone counts in playing a role to manage the risk that's associated with these individuals by providing support, or certainly having them take the extra precaution in terms of exposure.
Yes, thank you. And so similarly, we look at by parish, and the prevalence or the proportion is similar to what we saw for the other age group of 20.
Again, that slide, just go back there. That slide gives the breakout of those numbers by parish. So we're mapping the conditions, we're mapping the ages or age categories, and we're mapping the parish location. And we do more than that because we break that down to health center region.
So we're going to go down to next. So we went to a different level. We went to community level. We saw what our proportions were and number of persons were at the parish level and nationally. So we don't have health data to that extent at the community level. So we had to use other indicators to look at vulnerability. So we adapted a vulnerability index from US CDC, and we looked at 6 indicators. Crowding, that's the number of persons per room, the population density, poverty, highest level of attainment being primary school education, and population over 65, and then we looked at communities that had nursing homes and infirmaries, and we gave them a score between 0 and 1, with 1 being the highest. Then we summed all of those, and this is what the map looks like.
So this is the map, right?
This is the...
So the color scheme of this map, really lovely set of colors, but represents varying degrees of risk. Sorry, I was saying the color scheme on the map of Jamaica looks really lovely, but it represents varying degrees of risks or vulnerability. And it follows from a range of variables. So now you introduce not just age and comorbidity or sickness or chronic illness, but you introduce now education level, population density, how many persons live in a particular community, poverty, and therefore persons' ability to or inability to afford certain basic necessities, whether it's running water or medication. NHF does give free medication. Their nutritional levels, their nutrition levels may be compromised because they can't afford certain basic things. All of this combined contributes to a level of vulnerability. So you can now identify specific communities in Jamaica that would be vulnerable if Corona were to touch down in those communities. And so one of the objectives of government or the public health infrastructure is how do we sensitize those communities, identify them, sensitize them, and ring fence them if we need to, if the virus were to break out in those communities. Go ahead.
Correct. So this is the penultimate slide. We also mapped on this slide some vulnerable institutions. So infirmaries as well as correctional facilities are mapped. So each community will know their vulnerabilities as well as.
So what this slide does is to move now beyond just communities, age group, chronic ailment, and we look now at institutional vulnerabilities. And the obvious ones, and I commented on them in the press briefing, are infirmaries and nursing homes, and for obvious reasons. Primarily, those persons who stay in those facilities are older people. They have comorbidities, so they have the hypertension and the diabetes. They can't walk, some of them stroke recovering victims and so on. So the extent to which the virus, if it were to get into those institutions, those persons would be at extreme risk, which is why we take decisions around visitation and why those who are caregivers have to take certain precaution, because a breakout or an outbreak in those communities would represent significant challenges for public health and for those individuals. And that would include the prison system also.
So that's
it?
That's the presentation
Okay.
on the vulnerability.
I want to really thank Dr. Webster-Carr, and I hope those listening or looking on have an appreciation for a couple of things. Firstly, we have assessed the situation. The situation is not risk-free, but we have not in public health we're not ignorant to the risks that exist. In fact, we have tried to manage in a very deliberate way by defining those risks and defining down to the individual where in the country, who in the society are most vulnerable. And we have a very good sense of that down to the numbers and to the geographic location. The challenge now is, how do you, over the next 3 to 6 months to a year, because we believe, we're going to wait until we get a vaccine or we get a level of immunity across the country that will minimize the risk. How do we, over the next year, manage on a parallel track, opening up the country, freeing up movement, getting back to work, economic activity, travel, all of that, while managing those vulnerabilities, because it is those persons that have been defined that are going to be most at risk. Younger persons will get the virus, to be totally frank, and it will unlikely affect them in a long-term way. The challenge, of course, is that they will give it to older persons, and so that has to be managed. So the back-to-school protocols, all of those are critical. But what we're going to have to be watching over time is less the number of persons who get the virus, meaning the statistic around positives, and more those who are hospitalized or needing hospitalization. And a big part of our test for success, or assessment for success, will be the extent to which we save lives, prevent the vulnerable from dying, either by not getting it, or if they get it, we can quickly cauterize it and treat with it. All right, the next presentation will be by the Permanent Secretary, and he's going to look at the public health, the mitigating, the actions that are being taken based on the risks that are perceived. And this is, again, part of the plan going forward. Yes?
Thank you, Minister, and good afternoon to everyone. I have a very short presentation to make, just to complement the excellent work that is being done by our epidemiological unit here in the Ministry of Health and Wellness. In terms of how do we now, recognizing these risks that have been identified, manage the risk, mitigate them, or eliminate them? So we need to first begin our conversation, though, from the plan. And we started the conversation earlier in February around this plan, and the plan has 4 state phases to it. The interpandemic phase, and that's the phase between pandemics, and then we move to the alert phase, and then the epidemic phase, and the last phase is the recovery phase. But I would like to remind the public at large that we are still in the epidemic phase of the plan. We are not in the recovery phase, and therefore we have to be very conscious of the issues that arise during this phase, and that is why we speak about the existing risks and the fact that although we are bringing the population back to some sense of normalcy or normality, we have to bear in mind these risks, and we have to, as a public health response, ensure that persons maintain the infection prevention and control measures, and that persons are aware of their environment and take the necessary risk mitigation actions. And of course, the message of personal responsibility is paramount. We must be accountable for our health. Now, what have we achieved in the different stages? Of course, we know we have our points of entry and developments. So we have developed our protocols for the points of entry, our airports, our seaports, etc. And many of you will recall all of the activities, especially in the early days of the epidemic, when we had to implement our quarantine and our maritime rules as we looked at protecting the borders and protecting the citizens. So we have achieved a lot in the interpandemic phase in terms of building our capacity and especially building our infrastructure for testing and the strengthening of our National Influenza Center to undertake the testing once the protocols could be provided. In the alert phase, you recall that we launched early in the day our public education campaign. And this allowed the population to be alert and to be sensitive to the infection prevention control measures that were necessary to manage the epidemic once the first case arrived in the island and persons were easily able to transition from one state of operation to the next because of this early intervention. Now, because of these actions, in this alert phase, we were able to delay the advent of the disease, where 70 days after the WHO alerted to the cases in China and 39 days after being declared a public health emergency of international concern. That's when we had our first case, while other countries had their first cases long before that. And that is because of all of the measures that we put in place in terms of our border protection, our quarantine and isolation protocols. And these are major inputs to the delay strategy that was implemented as we move through the alert phase. Now that we're in the epidemic phase, we have already heard of some of the achievements that we have. We are now 86 days of the first case being identified, and we have had 10 deaths. Our mortality rate is around 1.6%, while the world average is around 6.4%. We have 591 cases already announced, 230 active cases. We have a 62%, well, this was from yesterday, where it's 61%, but today we have 62% recovery rate. We have 1.4% hospitalization of active cases. We currently have 315 COVID beds mobilized in hospitals, and R0, which is the rate of infection or multiplication of infection of less than 1%. So these are very, very good numbers. So how do we manage and maintain that infrastructure? So we have to look at where are the risks and how do we manage them. And this is not an exhaustive list, but this is just to outline to you how we are charting our risk and how we are seeking to manage those risks within the public health setting. So we have the first risk as being the increase in number of positive cases, and the risk impact here is around the increase in public anxiety. Every day you hear of an additional case, there's a certain level of anxiety, and it has the ability to overwhelm the capacity of the health system to respond. And so the severity of this risk is high, and the probability of this risk is high as we move to the next phase of the epidemic. But what are we doing? Our testing and isolation protocols for persons who are symptomatic are critical and are a very important part of our risk management strategy. The screening of all persons who enter the island, and of course, the quarantine of persons who are assessed as being high risk. The screening and quarantine protocol work hand in hand as a measure of managing the risk of increased numbers as we contain persons and prevent them from infecting others. Now, the other risk that we have identified is the lack of compliance and or control. If persons do not comply with the risk mitigation or the quarantining and the isolation protocols that we have put in place, we could have uncontrolled spread of disease. Now, what are we putting in place? The geofencing tools that have been developed and deployed, the support of the JDF and the JCF in providing resources to support home quarantining, the monitoring centers that have been established, the fact that we are increasing our cadre of public health officers in terms of community health aides to monitor persons, especially those with comorbidities, as pointed out in the risk communities that have been shown to you in the previous presentation. And of course, our public education program continuing to emphasize the infection prevention control measures that are critical to reducing the spread of disease within the population. As pointed out just now by Dr. Webster Carr, the whole infection of at-risk communities is a major risk component for us because it represents the probability of greater levels of poor outcomes from infections. And so, as you would have seen from the previous presentation, risk screening of communities is a critical part of what we do so that we can focus and target our interventions and ensure that we are able to manage the disease once it shows its presence in these communities. Individuals who have been identified as positive within these communities must be managed in different ways, therefore. So in terms of how we quarantine and isolate within these communities has a different flavor and texture because of the risk profile. So we have to ensure for these communities the heightened surveillance and the interventions that we need to utilize to ensure that we do not get the risk impact of a heightened death rate, which is something that none of us want to see. And of course, at the Ministry of Health and Wellness, and of course, right across the entire government, we are working hard to manage so that we keep our death rate within reasonable rates. Of course, we have a human resource issue within the public health system. This is not new. This is a fact that we have been working on before COVID, and we will, I'm sure, still have this reality to work with COVID. So therefore, the issue of personal responsibility for health looms large. We have, although increase the cadre of persons that are working with us. As the Minister of Health and Wellness has announced, over 1,300 additional public health personnel are to be employed to increase the cadre of persons. But we are also infusing in our approaches the use of technology to enhance our monitoring capabilities so that we will be able to work smarter within this new environment. And so the introduction of Gov't as one of the major WHO surveillance tools and the introduction of the COVID app in terms of the surveillance of persons in quarantine and isolation are critical tools to making the job easier of monitoring that we have to undertake as we go through this new normal. The final set of risks that we are managing is, of course, the risk of a natural disaster such as a hurricane. And what that what is the implication of a hurricane while we are managing this current scenario of COVID-19. As you would have seen from the Office of the Prime Minister, the disaster risk management plans are being updated or have been updated, and we are reviewing our shelter management protocols to ensure that they are compliant, that they continue to be compliant with the infection prevention and control procedures and rules, and to ensure that we monitor them for the new normal, for physical distancing, and also for all of the IPC measures that are to be utilized. We have undergone a process of reviewing all our health facilities to ensure that we have adequate supplies for the management of the interventions that are required during a disaster. And of course, we have looked at all the shelters for their readiness and ensuring that we have all of the stocks necessary for the eventuality of natural disaster, such as a hurricane during this time. But we have to be mindful of the fact that our health capacity still is fragile, and therefore we have taken some critical steps to ensure that the risk impact of sick individuals being unable to access care during COVID is either eliminated or significantly reduced. So we have dedicated 315 COVID beds in hospitals, over 75 ICU, HDU beds across the island. We are doing ongoing training for clinical staff in infection prevention control. We are doing our capacity development in treatment and care for infectious persons in HDU, high dependence unit, intensive care unit settings, and we are providing staff within the health facilities with psychosocial support to prevent burnout. And of course, we provide them with the necessary PPEs to ensure we reduce the risks of infection. Finally, we are monitoring and managing the outbreak in work facilities. And of course, we know that the risk impact here is the negative impact that outbreaks in work facilities have on the economy. And that is why, along with the private sector organization of Jamaica and other ministries, departments, and agencies, we have developed a series of protocols, and we are continuing to develop a series of protocols to manage the work environment and to introduce within the work environment the infection prevention control measures that enable persons to work in safe and healthy work environments. We are, of course, promoting the increased monitoring and inspections for organizations through self-regulation in the first instance, because we can't do it all, and it's a partnership that we are promoting, a partnership that enables all of us to be safe within the new normal. However, we are making moves to increase this cadre of staff, especially in the public health inspection field, for increased monitoring of the new protocols that we will be introducing. Now, finally, the importance of the stay-at-home orders for persons who have symptoms. These are just some of the risks that we are managing that we would want to bring to your attention, and for you to understand that the Ministry of Health and Wellness is a partner with all of society to ensure that we are able to move in the right direction. Thank you.
Thank you very much, Pierre. So there you have it. We will mount this on the website, or we could put this up on the website for persons to reference if they want to get a feel for what we're doing in terms of the risks and the plans to mitigate against those risks. So a very important part of the way forward. And I know it's a little lengthy, but nevertheless, we think it was important to outline it generally to the populace. The final, is there another presentation? A final quick presentation would be to look at the how Jamaica stacks up in comparison to the rest of the world in terms of some of the things that we have been doing. And I'm going to ask Dr. Webster-Carr to just quickly run through to give an indication of that.
Okay, thank you, Minister. So we look at some of the areas and the initiatives that we have or systems that are established in Jamaica. So these are our surveillance case notification, which is our class 1 notifiable disease system, our case investigation, and we have an established respiratory surveillance system which has been enhanced for COVID-19. Additionally, we do case investigation and contact tracing. The healthcare worker surveillance, there is an established tourist establishment surveillance which will become even more important in coming days. There is a general hospital surveillance where we look at admissions to hospitals and surveillance in special settings, which would include like the infirmaries. Then we have what is called participatory surveillance, and this is where we look at the hotlines and the Jam COVID appointment system. And then we have other targeted surveillance where we may look at special groups. So how these systems are important when we look at what are the recommendations for WHO. And when we look at the surveillance system for WHO, you see we get a ticky for everything because we are on the ball with what is expected for countries' surveillance systems to do. So when we do surveillance, there automatically comes out of it testing and laboratory surveillance. And so when we look globally, among the 313 countries and territories plus 2 international conveyances, Jamaica, when we look at absolute numbers of tests, Jamaica was 126th out of the 215, and when we looked at the number of tests per population, Jamaica was 128. When we look at positivity rate, so WHO has recommended if our positivity rate is less than 5%, then our testing is good. And so Jamaica positivity rate is 4.3. When you look at some of our neighbors, we're looking at 7, 13. And then there are some countries that are better than us at 1.6 as well. So, but Jamaica is doing pretty good compared to other countries around the world. When we look at the case fatality rate, that's the number of persons who would have died among the confirmed cases, then Jamaica has a case fatality rate of about 1.6 thereabout. And this is on a global website, and we looked at some of the other countries, and we have up to 14.3% for other countries, as seen in the diagram. So we also looked at countries with travel restriction. So it looks very blue. So most countries have at some level of travel restriction. Just a few countries have no travel restriction. So Jamaica is one with what is termed complete travel restriction. And then our final, that's it. So this is how we look compared to the rest of the world.
Okay. That's it?
Yes.
All right. Thank you very much, Dr. Webster-Carr. So there you have it, ladies and gentlemen. We've given you the update for the day. We've given you our approach to risk mitigation and management by looking at where the focus will be in the months to come. Vulnerable communities, vulnerable individuals, vulnerable institutions, what constitutes that vulnerability, underlying conditions, age, poverty, population density, and of course institutional vulnerabilities, nursing homes, infirmaries, prisons. Those are areas where we will place some emphasis going forward, and we've demonstrated or outlined a plan to do so. Public education being key, promotion of partnership between public health and the rest of society, but also preparing the hospital system, the health centers with more beds, more ICU units, more high dependency units, training of our staff, safety gears, and to give them the protection and the confidence to operate. The community health aides will be deployed in the field so that they can be in those communities. So, we do have a plan. The key messaging here is that public health is preparing. The success, however, of that plan is largely dependent on the extent to which the population complies, supports the measures that we implement, and essentially are a part of this process. As we like to say, everyone counts. Everyone counts. This is critical to the theme of personal responsibility, partnership, so that we can work together as a team. It's only left for me now to take my leave by playing a final little 1-minute video promoting the wearing of masks. It's part of the personal responsibility that we know persons do have control over. It's something we've been promoting throughout the country, and we'll be doing more of that as we go along. Thank you very much for listening, for watching, and we hope that you are more aware as a result of these discussions. Thank you, and please watch the screen for this short video while I thank those who are here in studio and those who have helped us to organize. This is our makeshift studio, of course. This is the Emergency Operating Center in New Kingston. Thank you very much.
The point of where
COVID-19 has significantly affected tertiary education. Universities and colleges have been adjusting to new ways of teaching. So, what's the impact on students? Join us for another RJR Gleaner Group virtual town hall this Thursday, June 4 at 8:30 p.m. on TVJ, JNN, OneSpotMedia.com, The Gleaner Online, Radio Jamaica, Power 106 FM, and TVJ's YouTube channel. Send us your questions to 876-381-0072. That's COVID-19 and tertiary education.
Hi there, I'm Simon Preston from TVJ. Thank you very much for watching our YouTube channel. To see our latest videos and also to see live events, click here. To see our full videos on OneSpotMedia.com, click here. Thank you very much for watching.
Reduce your risk of viral illnesses like the flu and coronavirus. Wash your hands frequently with soap and water. Cover your nose and mouth when coughing with a tissue and dispose of it.